Okay. All right. Today I'll be speaking about the development of the urogenital system. The system is made up of two components that differ functionally and structurally, and these are the urinary and the genital systems. Both systems develop from a common mesodermal ridge known as the intermediate mesoderm that is situated on the posterior wall of the abdominal cavity. The common cavity of cloaca, as shown in this picture, represent the future pelvic cavity, contains the excretory ducts of both systems. In the kidney system, the early kidney system is made up of three primitive forms that run in cranial to caudal directions. We have the proniferous, mesoniferous, and metaniferous. The proniferous is rudimentary and non-functional. The mesoniferous functions for a short time during early development, whereas the metaniferous that forms the permanent kidney. The first part, the proniferous, is represented by 7 to 10 solid cell populations that is located in the cervical region of the embryo. And as I mentioned earlier, this system is rudimentary that will disappear by the end of 4th week of development. The mesoniferous is located at the mesodermal ridge that extends from the upper thoracic to upper lumbar regions. The mesoniferous developed during the regression of the proniferous during the 4th week, and that results in the formation of the first excretory ducts. The mesoniferous tubules lengthen rapidly and form an S-shaped loop that is becoming rich in capillaries to form the Bowman's capsule. Hence, the renal corpuscle is formed. On the lateral sides, the tubule enters a longitudinal collection duct known as the mesonipheric duct, or it's called the Wolffian duct. By the end of the second month, the cranial tubules and the glomeruli degenerate, except a few caudal tubules, and along with the mesonephric duct that persists only in male embryos. These later will participate in the formation of the male genital system. The metanephros, or the definitive kidney, appears during the 5th week of development. The excretory units develop from the metanephric mesoderm, as shown in this picture, whereas the collecting ducts develop from the ureteric bud as an outgrowth from the mesonephric duct near the cloacal region. The pelvic bud penetrates the metanephric tissue, and upon the bud dilatation, the primitive renal pelvis is formed that splits into cranial and caudal portions, or what's known as the major calyces. Each calyx forms 2 new buds while penetrating the metanephric tissue. These buds continue to subdivide until 12 or more generations of tubules have formed. Meanwhile, at the periphery, At the periphery, more tubules form until the end of the 5th month. The tubules of the second order enlarge and absorb these of the third and the fourth generations, forming the minor calyces. During further development, collecting tubules of the fifth and successive generations elongate considerably and converge on the minor calyx, forming the renal pyramid. Thus, the ureteric bud gives rise to the ureter, renal pelvis, major and minor calyces, and approximately 1 to 3 million collecting tubules. The clinical correlates of this section includes the Wilms tumor, or what's known as the nephroblastoma. This is a cancer of the kidney that usually occurs in children by the age of 5, but may also occur in the fetus. Wilms tumor is due to the mutation of the WT1 gene, and it may be associated with other abnormalities and syndrome. Dennis-Drash syndrome consists of renal failure, pseudohermaphroditism, and Wilms tumor. There is also something called congenital polycystic kidney disease, where numerous cysts, shown in this picture, are formed. It may be inherited as an autosomal recessive or autosomal dominant disorder, or may be caused by other factors. So the autosomal recessive polycystic kidney disease, which occur in a proportion of 1 to 5,000 births, is a progressive disorder in which cysts form from collecting ducts, the kidney become very large, and renal failure occurs in infancy or childhood. The autosomal dominant polycystic kidney disease, cysts are formed from all segments of the nephrons and usually do not cause renal failure until adulthood. The autosomal dominant disease is more common, where the proportions may reach to 1% or to 500 or 1 to 1,000 births, but less progressive than the autosomal recessive disease. Complications in this case include hypertension due to the activation of renin-angiotensin-aldosterone system, frequent cyst infections, urinary bleeding, and declining renal functions.